Good evening. My name is Maneesh Bhatia. I am a consultant foot and ankle surgeon at University Hospitals, Leicester. I'm a member of Scientific Committee of EFAS and Education Committee of BOFAS. On behalf of BOFAS, I would like to welcome you all to the second episode of Master Techniques. Those of you who attended the last episode on calcaneal osteotomy gave us a lovely feedback, and hopefully you will thoroughly enjoy tonight's session. Before I introduce our first speaker, there are a couple of housekeeping announcements. Please post your questions through the Q&A function, not the chat function. And at the end, after the discussion, there will be QR code will be displayed, and you can use it to give the feedback, and then you will be issued the certificates. So without further delay, I would welcome our first speaker tonight, Pascal Rippstein, who is a senior foot and ankle surgeon, and he's going to talk us through his 25 years of evolution through open bunion surgery. Pascal is the founder and chief of department of the foot and ankle clinic at Schulthess Clinic in Zurich. He introduced and performed the very first scarf osteotomy in Switzerland. He has done a lot of humanitarian work and went to Vietnam to do foot and ankle surgery along with Samuel Baruch in 2014. He's a great educator and teacher, and he welcomes young surgeons to visit him. I visited him in 2009 and enjoyed it a lot and learned a lot, and I'm sure you will do the same. So over to you, Pascal. Pascal, we can't see you. That's it. Perfect. You're muted. Can you unmute yourself?
Is that fine now?
That's good.
Okay. Good evening, everybody. Thank you for the invitation and the kind introduction. Actually, I always love to come to your country because just, you kind of very special guys in England. You're excellent surgeon. I learned a lot from the English surgeon. And what I love the more about you is this excellent sense of humor. And therefore, I'm very happy to be with you here today. The only thing I'm going to miss is the fact that we'll not be able to have a beer together, but we will catch this up in Edinburgh at the EFAS meeting. So I'm going to talk about my experience with Helix valgus surgery open over 25 years. It's going to be an overview. I'm trying to give you all the steps I went through until the point I came now performing, I think, with quite success, bunion correction. Now, this will be an overview, and actually I used to say that each bunion has a kind of soul and own personality, and you have to know this if you want to be very successful in bunion correction. It's something which you cannot read. I'm actually writing a book on that there will be a very unique book because it's talking about things you never read elsewhere. And for those of you who cannot wait this book, about 2 years probably, you're always welcome to come and to visit me. So let's start with the talk. So how did it begin? So 1995, I had the chance of having 2 fellowships. I had 2 different teachers and I learned 2 different philosophies. The first teacher was Louis Samuel Baruch. He taught me about the scarf he introduced in Europe. And actually his opinion was that all bunions should be corrected with scarf. The other teacher was Ted Hansen. Ted Hansen taught me the lapidus. That was the time where, for the first time, people were talking about the first ray instability. And for Ted Hansen, it was quite clear that this instability was the reason for the bunion deformity. And therefore, he stated that we need to stabilize the first ray. So coming back to those two fellowships, I had to make my decision. And I decided that I would use the Lapidus procedure for the IM angle 1-2, which would be superior to 18 and or first ray instability. The scarf would be suitable for IM angle 1-2 under the 18 degree when the first ray would be stable. Now it's interesting to see the numbers. That was 1996, the first year I went back for my fellowships. 44 bunion correction, and 2/3 of them was scarf, about 1/3 of them were Lapidus procedure. Now, 25 years later, having performed almost 10,000 bunion correction with scarf and Lapidus, this distribution has changed. And you see, last year I've checked the numbers. I did 92% of scarf and only 8% of Lapidus. So let's have a thought about this change of distribution. With the Lapidus, what I liked and still like is the fact that you correct the deformity at its base. And actually, if you think about that, that's the very most logical correction you can achieve, because what we have with the Helix valgus deformity is a metatarsus primus varus, which is tilting in the medial direction. It's like you would ask an architect to straight up this Leaning Tower of Pisa. He surely will not do it this way. He will do it this way. Well, we are not architects. We also have our Leaning Tower of Pisa, and this is the metatarsus primus varus. And again, here you can decide to correct it somewhere at the base or even more distal. That will create a kind of zigzag, or you can go at the base of the deformity, and then you will have actually a very logical correction. What I like about the Lapidus procedure is also the fact that you can correct any amount of deformity, even the worst one, you always will be able to correct them. But there were many things I didn't like over the time with the Lapidus procedure. The first thing I realized is you always create the first metatarsal shortening, and therefore you get in many cases transfer metatarsalgia. Also, because it's a joint fusion, you had a risk of TMT-1 pseudoarthrosis, and for this reason, we put our patient on partial weight bearing, and that was also something which was not always fun for patients. Because of that, we just could correct one side at the same in a surgical procedure. We couldn't do bilateral correction. And last but not least, you leave a second scar on the dorsal aspect of the foot, and ladies usually are not very happy about that. With the scarf, I didn't have those disadvantages. I have no shortening of the first metatarsal. If I don't want to have one, I can do it, but I don't have it if I don't want. The consolidation will be very fast and reliable. I can put my patient on a full weight bearing immediately, and therefore I can operate both sides in one stage surgery. I also leave just one single scar on the medial side, and therefore with the scarf actually, in comparison to Lapidus, I was very happy, and so were my patient too. And so I was thinking about, well, I love to make the scarf, the Lapidus is creating me more problem. Could I solve those problems which have been told you can solve with the scarf? That means, can I address in a way or another the first ray instability, and how should I deal with more severe deformities? Well, let's start first with the first ray instability. This has been my experience over the years. I can say today that for me, most first ray instability are functional. That means this motion you have in the first ray, which is in the sagittal plane, is not located at the TMT1 joint, and therefore, in those conditions, the TMT1 fusion is not going to stabilize anything. It's a motion which is located between the first and the second ray. So the first ray is stabilized actually by the windlass mechanism. I'm sure that you're all aware about this mechanism. I'll show you it again here. You have here the fascia plantaris, which is an elastic structure, very stiff, and it's inserting at the base of the big toe. When you make a dorsal extension of the big toe, this will put the first metatarsals in plantar direction, so it will stabilize the first ray. And when do you do an extension of big toe? Each time you do a step. So actually, what is happening with the bunion deformity is a failure of the windlass mechanism. This creates the first ray instability, and that's a functional one. If you correct the bunion, and regardless how you're going to correct it, you will repair this windlass mechanism, and your first ray gets stable again. So the type of bunion correction, if it's fusion like a TMT1 fusion Lapidus, if it's osteotomy like a scarf, whatever kind of osteotomy, is absolutely irrelevant. What is important is that we restore this windlass mechanism. So I realized over the years that the TMT1 fusion, the modified lapidus, was absolutely not mandatory to stabilize a so-called, what I call a functional first ray instability, and the scarf I love to perform will work as well. Now, I still had to deal with the severe deformities. I would have loved to correct them also with scarf, but I had to find out how far I could push the limit for the indication of scarf, and this is I learned over the years. And I realized that actually with a scarf, you can get a stable scarf when you have what I call the 3 point of fixation. And actually, there are 3 points which are fixating the distal fragment. The distal one is an overlapping of both fragments, which should be at least 3 millimeters. At the shaft, you should have at least a contact between cortex and cortex. And proximal, your both fragments should be locked into the Z-cut, which is also a stabilizing structure. This is the case again, and you see by how much I could here translate the distal fragment laterally and leave this performing a huge correction. Now, for those of you who think this is not going to be stable enough, this is the situation 1 year later, and you see perfectly aligned and the bone has healed. These are a couple of cases. Here again, a maximal translation, 3 point of fixation, distal, cortex, and Z-shaped proximal. Again, here one maximal translation. And all these cases are healing because they're stable enough. Here, even bigger deformity, again, with healing. So actually with the scarf, I realized I can also deal with severe deformity. So nowadays, I use the lapidus only in some few cases. I use it if I have to deal with a massive bunion deformity. A massive means when I perform the maximal translation, when I perform the lateral translation of the distal fragment, bringing back the distal fragment to the place it belongs to have a normal intermediate angle 1, 2. If I don't have an overlapping between both fragments, allowing the fixation, then I will not for sure be able to perform a scarf. I will use something more proximal. And in those situations, because of the more logical correction at the base, I use the lapidus, the modified lapidus. Now, I also use the lapidus for the true first ray instability. These are structural instabilities. They are due to a joint laxity or sometimes because of severe long-lasting flat foot deformity. In those cases, however, you have to realize that the TMT1 fusion alone is usually insufficient, and you will need to stabilize the first ray to the second ray, which is very stable. That's actually the technique which has been described by Lapidus. This is the original Lapidus. This I perform nowadays only in about 10% of cases. Now, one of the most important things I've learned over the year is that you absolutely need, it's mandatory to balance your hallux. That's the key to the success. And the lateral medial balance is absolutely essential. So I started with the classical way I learned from my mentor. On the lateral side, we would perform a release, and usually you make a tenotomy of the adductor tendon. On the medial side, you may perform a tightening of the capsule, a capsule raphe, and that was the way I was taught to balance the whole thing. But actually, I wasn't really happy with it because on the lateral side, if I was too aggressive, I could get a varus, which was unfortunately happening. And if I was not aggressive enough, then I could have a valgus recurrency. On the medial side, when I try to balance the whole thing by tightening the capsule, I realized that the capsule was not holding the correction over the time, at least maybe 1 month, 2 months, or a year, but then the bunion was coming back again. So I was asking myself if I really needed to release the lateral structure, and if I couldn't get this big toe straight, aligned, without having to perform a medial tightening, which was anyway not holding the whole thing. Well, you have to think what you want to achieve with a bunion correction. The goal is to bring back your first metatarsal head over the sesamoid, okay? And to achieve that, actually, you need to open a door in the soft tissue. Otherwise, you will not be clearly able to bring back this head at the correct place. So what you need to do is a door in the lateral MP1 capsule. And this is the way we do it. I detach the soft tissue from the dorsal aspect of the phalanx. This allows me to luxate the big toe plantally. Then I use a beaver knife, which is cutting in front and the sides, it's slightly curved. I push this blade inside over the lateral sesamoid, performing an incision. And then I move forward and backward. This gives the door, and that's all actually. Nothing on the tendon, adductor tendon. And actually, what I'm doing this way is opening the door, and in this door, I will be able to move the head over the sesamoid. That's a small arthroscopy. You can see the beaver blade just over, that's the head on the top, and underneath you see the lateral sesamoid, and the blade is just going through the capsule right over the sesamoid, opening the door, allowing the reduction of the head over the sesamoid. Now, the advantage of leaving the stabilizing structure on the lateral side, meaning the adductor, was that the risk of hallux varus was clearly reduced. And this allowed me to push the correction to its maximum. And pushing the correction to its maximum had increased the power for my hallux correction. And nowadays, I would say I almost always translate maximally the first metatarsal laterally, and I additionally add an echinostomy, but that's another story. Now, what you have to realize, and that's probably the most important thing, it's absolutely mandatory during the surgery that your metatarsal head is reduced over the sesamoid. Your big toe should be well balanced on lateral medial side. And what you want to see during the surgery is that when you make the push-up test, which is a simulated weight-bearing situation, you want to have your big toe aligned without any forces pulling in varus or valgus. You see here, the capsule is still open. We didn't do anything, just this opening door and pushing the head over the sesamoid. We want to check that your head is really over the sesamoid, and you can see here, the medial sesamoid is centered on the metatarsal head. And if you check this with a fluoroscopy, again, the capsule is not closed here. You see that having performed this door on the lateral aspect of the MP1 joint and having moved the distal fragment laterally, we got a nice alignment. And this situation will provide a long-lasting good result of the correction. But sometimes I had to realize that this will not always work that well. And sometimes you cannot reduce the head over the sesamoid. Well, I stopped to expect anything from a capsulorrhaphy because I realized that this is losing its power over the years and the hallux is coming back. So I start again to classically release the lateral soft tissue with a tenotomy of the adductor, eventually of the lateral flexoris brevis tendon. But I was still not very happy because again, I got more risk of hallux varus. And especially I realized that doing that, I still had quite a big tension in the MP1 joint, which is more likely then to produce a recurrence. So how could I keep the lateral structure still intact if I cannot reduce the head over the sesamoid? Well, the answer to that is the first metatarsal shortening. This decompresses really good the MP1 joint, and you can leave this way the soft tissue intact. The adductor tendon, again, you don't need to cut it, so the stabilizing structure is still there. It's the most powerful tool to balance an MP1 joint. As you can see here, a severe deformity, contract situation, just by shortening the first metatarsal without making an autonomy, I could realign the first ray. The reverse side of the medial, you have to shorten the lesser metatarsal, but anyway, in those situations, they mostly also luxated, so it's not a big deal. You have to do something here. Again, here, severe luxation of the lesser metatarsal joint and this severe hallux valgus deformity, just by shortening a realignment of the whole thing, balancing of the soft tissue around the MP1 joint. Again, cases here. So on medial side, I totally stopped to perform any kind of tightening. I just resect the excess of capsule and I close the capsule in neutral situation. So very shortly, my evolution in bunion surgery, I realized that the first ray instability is frequently functional and that the lapidus is in most of the case not mandatory. Or you can just perform osteotomies as long as you correct the deformity, you will restore the windlass mechanism, and this is a valuable alternative to lapidus. I realized that with a scarf, if you experience with that, you can do an extreme powerful correction. And nowadays, with this kind of osteotomy, I can correct 92% of my bunion case. That's the most important thing. Balancing the hallux is essential. On the lateral side, I don't do any destabilization by cutting the adductor tendon. I just make a longitudinal incision to open the capsule and allow the head to go through this open door. I always try to put this way with lateral stabilization, lateral translation of the metatarsal head, which is improving and increasing the power of my correction. On the medial side, no capsule tightening. This is useless. This will come back again. If you need to tighten your capsule medial side, something is wrong. And finally, if you cannot balance the soft tissue doing that, then the solution will be the first metatarsal shortening if the hallux is still not perfectly balanced. So Maneesh, I have a small video. Is it time or should I leave?
No, it's okay. Okay, we have time.
Okay, so I just want you a small video showing the feeling you can expect when you're successful with your bunion surgery.
You lost. Oh, how does it feel to lose? What? Oh, yeah.
Thank you very much.
Thank you very much, Pascal. That was brilliant. I'm sure there will be lots of questions people would want to ask, but thank you once again, and we'll have the discussion session later. I'm going to now invite our second speaker, who is going to talk about the other way of doing bunion surgery, that is minimum invasive. So David Gordon, who is a consultant foot and ankle surgeon, he's full-time in private practice in London and Hertfordshire. He did 1 year of fellowship in Australia, in Sydney, and he has been doing minimum invasive surgery since 2013 and has done over 700 minimum invasive bunion surgery using Mika technique. He has published, and he does a lot of presentations and travel around the globe teaching minimum invasive surgery. So over to you, David.
Thanks, Maneesh. I'm getting an error message regarding starting my video. Do you mind just allowing me to start my video, please?
We can see your video.
Yeah. Perfect. You can see my video. Okay. You can't see me though.
I can't see you, but I can see the video.
Yeah. Could you just activate my camera so you can see me?
Sure. Toge, can you just see so that we can see David?
Yeah, so still not great. Okay, perfect. Thank you. All good. Good evening, everybody. Thank you so much for attending, and also thank you to BOFAS for inviting me to give this talk. And Pascal, that was a really enlightening and very interesting presentation. So thank you as well. Be very interesting and fun to have the debate once I finish my presentation. So my name's David Gordon. I'm going to talk to you about minimally invasive hallux valgus surgery. So I'm going to give you an overview initially, a bit about the history of minimally invasive surgery, the evolution, the technique, what I describe as the up-to-date technique, what I perform, a bit about training and the learning curve, new technologies that are coming through that might make access to this type of surgery easier, and then go through the advantages and the disadvantages of minimally invasive surgery. And then I'll talk about the literature, the results, and also my personal experience. So what is minimally invasive surgery? Well, it means different things to different people, but effectively it's performing surgery through small incisions. And it's about preserving the soft tissues. So rather than doing a large incision like Pascal has shown, to perform the scarf and splaying open that first metatarsal and the joint, minimally invasive hallux valgus correction can avoid that and the risks associated with it. What minimally invasive surgery doesn't describe is the type of osteotomy that's performed, nor whether fixation or not is used, and if fixation is used, how it's used. And it doesn't involve any endoscopic procedures. The history really dates back to this American podiatrist, Morton Polakoff, who first described performing minimally invasive surgery in the foot in 1945. Then we kind of got a big jump of about 46 years before anything further is published on the topic. And Stephen Isham published his results using a reverdin osteotomy, but rather than the reverdin being an open osteotomy, which is a closing wedge of the metatarsal head, he performed it minimally invasively with specialist instruments called burrs. So he started that in 1986, published his 5-year results in 1991. And this is what we call the first generation, where there was no fixation used when performing the surgery. Very similarly at that time, this is Reverdin's paper in 1881. I don't speak French, so I've not read it. But moving on to the second generation, which was published the same year as Stephen Isham's, again in 1991, but this time using a different osteotomy, a transverse osteotomy known as the Bosch, and using a type of fixation, i.e. a K-wire. So unstable fixation, but some fixation nonetheless. And this is what we class as second generation using wire fixation. We sort of have to jump 22 years till we get to the third generation of minimally invasive hallux valgus correction, where Joel Van Waar and David Redfern published their series, this time using screw fixation, so internal fixation. And there's been a real evolution using screw fixation within that third generation. And it's very confusing when you read the literature what third generation minimally invasive surgery for hallux valgus actually means. You've got lots of acronyms floating around. It seems like every week a new one pops up. The most popular one that you may have heard of is MICA, and that's the technique that I'm going to describe to you, and the technique that Joel Van Waar and David Redfern established. So that's minimally invasive Chevron Osteotomy. But different people do MICA differently, and I'll come on to that in a moment. And that makes comparing the results quite difficult. Another acronym, PICA, percutaneous Chevron Osteotomy, is very similar. There are others as well, such as PERC, MEBA, and PICO. So some are extra-articular, some are intra-articular, some are fixed with wires, some are fixed with 1 screw, some with 2 screws. If we look at third generation techniques, these are some snapshots from the publications. You've got this variability. So if you look at the images, you've got a dorsoplantar screw, single. You've got an intra-articular osteotomy, again, dorsoplantar single screw. And on the far right, you've got 2 screws. One is going more medial to lateral, and a second dorsoplantar. So a lot of variability. So even MICA itself has evolved from when Joel Van Waar and David Redfern initially described it. This is their image from their publication in 2013 on the left, single screw. It's then evolved to 2 screws, purchasing the lateral cortex of the first metatarsal with a proximal screw, and these are 3mm screws, and then moving on to the far right image to 4mm screws for stronger screw purchase, potentially. So I'm going to talk to you in a bit more detail about minimally invasive Chevron Osteotomy, which is the technique that I perform, and just go through the surgical technique briefly. You need specialist instruments. So you need burrs, different types of burrs, which are shown on the left. You need a burr handpiece, which I'm holding in my hand there, to turn the burr. Then you need an irrigation system and a control unit and a foot pedal so you can manage the rotation of the burr. You also need a cannulated screw system, and there are various chamfered screw systems on the market. So the chamfer of the head allows the screw to sit flush with the medial bone so as not to be palpable. All my surgeries performed under ankle block, and most patients have some light sedation. Some patients are awake, and some patients have a more deeper sedation. You need intraoperative X-ray throughout, either a mini C-arm or an image intensifier. Certainly it's easier with a mini C-arm that you can move and control yourself. And the patient's positioned with the foot dangling off the end of the bed, so you can get your image intensifier underneath and get a good shot of the foot. Typical bunion deformity, a moderate deformity here, and I'll talk you through the steps in order to correct it. So the first step is using your burr to perform a Chevron Osteotomy. So that's a dorsal and plantar cut. Then once the osteotomy can be completed, you can correct the rotation of the metatarsal head and the hallux. And then the metatarsal head is translated laterally with a lever. So intraoperatively, you've got a lever pushing the head over, and you can push it as far as is required, but normally I push it 95%. And then I have a 2mm KY ready to fire through the lateral cortex to gain purchase in the lateral head. And then you fire your second wire, and then the 2mm KY will be replaced with a finer wire, so you can drill over that and replace both those wires with 2 screws. So you end up with this configuration of 2 4mm screws. And then you have this spike. So this spike needs to be removed, again with a burr, as pictured. And then often there's still a bit of a bump on the medial eminence, and that's shaved down with another burr, just to make a nice smooth medial border of the foot. And then if one needs a lateral release, that's performed percutaneously. And then a decision's made whether an Aiken osteotomy is also required. And again, that's using a minimally invasive technique with the burr again, and then screw fixation. So this is the Aiken on the left after I've created my cuts before closure, then manipulation to close the Aiken, and then fixation with the screw. Wound closure, no sutures required, just steri-strips, and then a bandage. So typical pre-operative and post-operative corrections. So the red lines demonstrate the intermetatarsal angle and the hallux valgus angle, and then the pre-operative and post-operative clinical photographs. Typical incisions, so you have a small incision here and here, and then if you need to perform an Aiken or a bunionectomy, then, well, an Aiken, you'd have 2 further incisions here, but that's quite typical. You often get some quite scary looking x-rays if you're not used to looking at these, but you know, with time you can understand the healing potential of the body. So you can do very large translations, so that's why it's appropriate for severe deformities as well as a full range of others. And the reason why you can do that is because the body has an amazing propensity to heal and lay down new bone. So as we know, bone is the only living tissue in the human body that can heal without scar tissue. And you can take advantage of that by creating big translations and allowing the body to heal naturally. And so in the middle, you've got a 6-week post-operative radiograph, and you can already see the sort of fluffy callus formation forming. That's not, you don't always see that at 6 weeks, but when you do, you know the patient's going to heal rather rapidly. And at the 6 months, you have excellent bone consolidation. It's an important technique to train on, particularly with sore bones before you do this surgery, you know, in real life. It is unfamiliar instrumentation. The movement and the actions of the hands are very different from what you might be used to. So you must practice on sore bones, get as much support as you can from colleagues who do the surgery and your representative from your medical device company. And it's good to start off with some simple non-hallux valgus procedures like a chilectomy. So Ezekiel Palmanovich in Israel published his paper a couple of years ago looking at the learning curve. So the orange bars are his surgical time on the far left in minutes, Case numbers are on the x-axis, and the blue line are the number of image intensification images. And you can see things start to flatten out at around the kind of 30 case mark, and then on to 50. So when you start this procedure, you need to leave yourself plenty of time in your operating list. And you just got to take your time, and you will get quicker. If you want to start out, what would be an ideal first case, an ideal bunion? Well, something like a moderate hallux valgus. A mild hallux valgus is not an ideal case. A moderate one is. A patient with good bone quality. You don't want to start this out on someone with osteoporosis. A wide metatarsal head to give you plenty of bone fixation, and a large medial eminence. So when you do that bunionectomy, you can take off lots of bone, and the patient's very happy with that. You want to avoid severe deformities, avoid osteoporosis. If you have someone with a narrow first metatarsal, when you perform that translation, you'll very quickly find you're translating it even greater than 100%. And that can be quite a scary thing if you're starting out. If someone's got hypermobility, similarly, you can end up having a very large translation of disparity between the shaft and the head. And a heavy patient can also sometimes bring challenges to the quality of the fixation. But this would be this is the patient who I showed just the slide before. So you get a nice shift across about 80%, and a good purchase with your screws and good bone remodeling and a good correction. Same patient with a 6-month clinical photograph post-operatively. There are new technologies coming in, which principally they are jigs, and these jigs are designed to allow you to fire your K-wires across the first metatarsal into the metatarsal head with better accuracy than freehand, to make it more predictable and more reliable. I have to say, they certainly have their merits. I think it's early days. I don't think the evidence is out there yet. They've only recently been released, and there are a few on the market. So time will tell whether these allow newcomers to the procedure an easier entry into it rather than learning the technique freehand. I.e., can we reduce the learning curve or make it quicker to learn with these devices? That's not yet proven. So for me, talking about, listening to Pascal, it was really fascinating, particularly the degrees of correction that he was demonstrating, which I was very pleased to see. But for me, the advantages of minimally invasive surgery over a scarf are you can use this technique, MICA, for mild to severe deformities. I don't personally have any exclusions. I don't do Lapidus. Every patient that I see will have a MICA if appropriate and clinically indicated. You can perform very large intermetatarsal and hallux valgus angle corrections. You do not rely on the medial capsular plication, which I was very pleased to hear Pascal comment on, because when you do such great shifts, and that typically can be, well, certainly with MICA, but also in scarf, if you can shift that much, the tissues then relax. You have a balance. You're using your bony cuts to balance the foot. You don't need to rely on any medial capsular plication, but you do have much smaller incisions than a scarf. So you have less wound complications and less wound healing problems. One thing I'll mention in a slide in a moment to explain how you can increase what I call the proximal intermetatarsal angle. What you're doing is you're locking out the first TMT joint. I'll come on to that in a moment. And because of the reason why you can stabilize that first TMTJ, I believe you reduce the recurrence rates. You have the ability to perform a 3-dimensional correction, where in my hands at any least, I don't believe you can with a scarf. How do you really derotate that and correct that pronation at the metatarsal and not cheat by doing it through the Akin? You're preserving the joint, you go nowhere near the joint. And once you're up to speed, in my hands anyway, the surgery is much faster than a scarf. So I just added in this slide while Pascal was talking, and I found it fascinating that with both principles are very similar. The bony correction is really, really important. You've got to get that big shift across. If you're shy with your shift on a scarf, you're going to rely on those soft tissues and they are going to fail. You will get recurrence. I see, I do perform MICA in revision situations following scarf, and I can see, where those undercorrections, those small shifts have not been adequate enough. So you don't rely on that medial capsular repair. And we also talked both about, minimal lateral release. I'm not doing big lateral releases of the adductor. It's a very small lateral release, similar to Pascal. So, can you do this with a scarf? So, can you get these big translations? You probably can with experience with the scarf, absolutely. But I think in my view, most people maybe not be brave enough to shift this sort of degree, with a scarf and have the same result. And I think really the rotation. So if you look at the nail and how it's so pronated, you can really derotate that metatarsal head, back to anatomical correction. So I talked about the proximal intermetatarsal angle. So when I say proximal, if you look at the metatarsal angle, the first metatarsal angle proximal to the osteotomy, I've measured it with the green line. So I'm not measuring the intermetatarsal angle here. I'm measuring the proximal intermetatarsal angle of the first metatarsal against the second. So you've got 11 degrees to 24 degrees. So I'm increasing that intermetatarsal angle. I'm locking out that first TMTJ, and the blue arrow is pointing to that big gap where between the first and second metatarsals, where you are really jacking it out. And I believe this will reduce your risk of recurrence, because that first metatarsal, that first TMTJ has nowhere to go, nor does the first metatarsal, because you've locked it out. And that's the aim when you perform this surgery. And that's why you can get these big mismatches between the metatarsal shaft and the metatarsal head, and over 100% if needed. So let's look at the literature. Well, overall, MICA has shown over a number of publications that clinical scores improve, as do radiological parameters. You get low recurrence rates. You have a full range of deformity correction, and similar complication rates to open surgery. There are disadvantages. So access to training, unfamiliar instrumentation, the learning curve is longer, and you do have X-ray exposure. There are two meta-analyses published comparing minimally invasive hallux valgus surgery to open surgery. So Xi published this year, and Ferreira published last year. So I'm going to talk you through those. The first meta-analysis by Xi et al., open versus minimally invasive hallux valgus correction. So the authors found 22 studies, a relatively matched comparison of numbers, and they found that minimally invasive surgery was better for sesamoid positioning, correction of the DMAA, post-operative pain, and length of stay. No difference, however, in the HVA, IMA, shortening, AOFAS, VAS, and complications. Subdivisions of that, because you've mixed in all generations of MI surgery, but looking at third generation with screw fixation, the hallux valgus angle improvements were better. And looking at the RCTs, for minimally invasive surgery, the AOFAS was better, but we're looking at very small numbers. The blue lines represent the RCTs. So Lee et al., which is Peter Lamb's group, comparing PICA and SCARF, which I'll go on to a little bit later, and Kaufman. Now, if you look at this meta-analysis, the second blue line on the bottom, Kaufman et al., he describes the MIS technique as MICA. You look at his paper, which was published in JBJS 2020, 5-year follow-up. This is not MICA as we know it now. This is maybe a chevron, but it's fixed with a wire. So minimal translation, minimal correction. Very difficult to compare that now to SCARF. So there's also been a systematic review. So Ferreira in Sao Paulo and authors, Gabriel Ferreira in 21 published this. So he searched up to 2020. He found 3 studies comparing SCARF and minimally invasive hallux valgus correction. So in total, 235 feet. Overall found that radiographic correction was similar, as was pain and function. And this is up to 6 months, but longer radiation exposure time. So I'm just going to delve in a little bit into those 3 papers. So these are comparing SCARF with minimally invasive hallux valgus correction. So Frigg looked at roughly 50 to 48. Severe hallux valgus was excluded. The author had 2 years experience, but if we look at the technique used, this is not a Mika technique, as I've described. This is with 2 screws going sort of dorsoplantar, medial lateral, not purchasing the lateral cortex. So again, I wouldn't interpret these necessarily equally with the Mika technique. However, there was a conversion rate to open, 14%. There were high wound complications in the scarf. It was slightly slower, the scarf operation to perform. There was a higher reoperation rate in the MI group because of screw removal predominantly. Stiffness was equal. Recurrence rates 6% in the scarf, 4% in MI at 2 years. And conclusion was no advantage over scarf. So Lay et al. Published in 2017, similar kind of 58 scars, 29 MIS. And again, a different technique from Mika, the modern technique that we're using now, 1 screw dorsoplantar. However, comparable scoring at 24 months, but less pain in the minimally invasive group, a shorter length of operation time, some more wound complications in the scarf group. So finally, this is probably the only study to date which truly compares a 3rd generation minimally invasive hallux valgus correction technique, PICA, with scarf. And this is Peter Lamb's group in Sydney, Australia. So an equal number of 25 each, 2-year follow-up. The scores of both groups improved. The corrections were similar. PICA was faster to perform and did demonstrate less pain. So in summary, you've got good clinical outcomes for Mika, or minimally invasive surgery. You've got low recurrence rates, low morbidity, smaller scars, less pain, shorter operative time, quicker recovery, but this is a real mixed bag. I'm just going to present to you some of my work with my co-authors. We published this last year in the JBJS America. So this is a large series of Mika that were performed by myself. So we presented 333 feet. We had 88% follow-up for outcome scores, the MOX-FQ, which meant we had a full data set of 292 patients. 96% were followed up for X-rays. And I performed Mika on the full range, so mild, moderate, and severe. So the top red circle, a quarter were mild, and a quarter was severe. Majority were moderate. And if we look down at the IMA column on the left, preoperatively, the mean IMA was 15, reduced down to 5.7. The maximum IMA was 27. On the HVA group, the preoperative was 32, down to 8.7, and the maximum HVA was 63.9. So briefly, the radiographic scores improved. This is results from our paper, HVA down and IMA improved. And, this is about function. So this is 2-year MOX-FQ functional results compared to preoperatively, and significant improvement in all the domains of the MOX-FQ. So in summary, you really need adequate training experience for the Mika technique, but it is safe and very effective with low morbidity. It's more versatile in my hands, I believe, than scarf. You get good and excellent clinical outcomes with low recurrence rates, but obviously this paper was a 2-year results, and the 5-year data will be compiled and presented hopefully next year. And patients are very satisfied with this technique. I'm just going to wrap up by a call for collaboration. So please take down my email address. I've got a very large data set, very keen on disseminating knowledge and publishing. So if you want to get involved in any of my work, please do get in touch on social media or via my email. Thank you very much. I look forward to the discussion now.
Brilliant. Thank you so much. That was a very, very detailed, comprehensive presentation, David. And I'm sure the audience have all enjoyed it, listening to both of you. So we can get Pascal and David on the screen so that we can start the discussion. So I've got a few questions here coming up. So the first one is to you, Pascal. Are you there, Pascal?
Yeah, I'm here, but the video, okay, now it's okay.
Okay, so the first question is to you from Tom Lewis about long-term recurrence, more than 2 years. What is the long-term recurrence, Pascal?
Well, I think, I don't want to answer this question with numbers I don't have, but what I've experienced over the years, if you get the reduction during the surgery, you have a balanced hallux, it's a reduced head over the sesamoid, then you get a result forever, almost all of cases. And that's all a matter of having nice reduction. I'm sure it's all a matter of technique. If you use the mini-invasive, the open technique, at the end is the ability of the surgeon to make a correct reduction and balancing of the tissue will give the good results.
Same question to you, David.
So I really agree with Pascal in terms of how you get that correction, and I think for the scarf, I think people maybe aren't brave enough to really give it that big shift, which is what I've learned with the Mika technique. So the recurrence rate was 0.9% at 2 years in my series of 292 patients that I presented just now. Those 3 cases were very severe hallux valgus angle. And I think there are maybe some limitations in terms of the soft tissue correction you can get with that kind of angle. Even if you get a balanced hallux valgus correction, you've got significantly stretched medial capsule. I think sometimes you might need to maybe do a little open procedure, even when you're doing minimally invasive, just to tighten it up. But I think I've learned from those recurrences, and I've changed my technique slightly to reduce that. But the published in my series was 0.9% at 2 years.
That's very fascinating. Another question, Pascal, from one of the audience is how to avoid troughing when you're doing so much correction?
Well, one way to avoid it is to make your cut distally very forward in the head, because in the head you get a good dense spongiosa bone, and this gives good support to both fragments. And again, this 3 point of fixation, you have to be careful. If I don't mind about moving a lot, like David showed it in almost all the cases, moving a lot the disc fragment laterally and getting then this way a long contact on the cortex. Then if you get that, you don't get the troughing. And then again, the 3rd point of fixation, the Z cut proximally is also important.
Okay. Question for you, David. So a couple of people have actually commented on this. They've asked, can you explain locking of the first TMT joint? Is the first question. And the second is, locking the first TMT joint, does it not result in arthritis of that joint?
So yeah, forgive me if I didn't explain it accurately enough in that slide. But if you imagine your first TMTJ joints, if you can see my pen, so with your hallux valgus, you have an increase in your IMA. So here's your second met, first met, you have your intermetatarsal angle. You make your cuts, subcapital cuts. This metatarsal proximal to that osteotomy then can move considerably more this direction. So in doing so, you're progressing effectively that 1-2 intermetatarsal angle. But of course you're not, because you've shifted your head back. So you're pushing, you're effectively doing your pull technique as you would describe in your scarf, when you're pulling that proximal metatarsal to open up that intermetatarsal angle even further. Then you do your translation and fixation. So I hope that explains it accurately, but that's what you're doing. You're locking out that first TMTJ, so it's not moving anymore. So when you do a squeeze test, you can actually squeeze, once you've done your correction, you squeeze between the second and the first metatarsal heads to see if you can push that metatarsal, the first metatarsal head, more medially, and it just won't budge. It'll be absolutely locked there. I've had no cases of first TMTJ pain or degenerative change at all. So, it's a normal joint just placed at its extreme. So I think it's within the anatomical parameters, but no, not seen any degenerative change in that region at all.
If I can, no, sorry.
Sure, Pascal, please.
Okay, one problem I've seen with that, I agree totally with you, and pushing the proximal part of the metatarsal toward medially is producing a kind of spring effect, trying to pull the whole metatarsal back in toward the second metatarsal, because you pull the whole proximal part medially, and this, once you leave it, tend to go back to laterally. Now, the thing is, I've seen sometimes is that you increase the obliquity of the TMT1 joint. And I've seen some case where the joint is slightly dislocating at this level. Was not many cases, but it didn't produce any problem. But I was a bit concerned about this. Probably the forces acting at the TMT joint are changed for sure, and this might lead to a shift of the joint. Yeah.
There are lots of questions. I won't be able to take them all. Maybe I might send it to you, Pascal and David. But just last couple of questions. David has also already mentioned that it takes about 30, did you say, learning curve, about 30.
I think in the literature, numbers around the 40 have been described. I personally, and be interesting to see what Pascal says, I'm still learning this operation, 700 plus cases. So you're always learning. So what do you mean by, you never mastered the surgery, I don't think. I think you're a fool if you think you ever master it. Because the moment you think that, something's going to happen. So look, I think to be reasonably competent with a reasonable surgical time, reasonable number of x-rays, 40, 50, but you've not mastered it by any stretch of the imagination. And I think that goes for any surgery, to be honest.
Thank you. Pascal, this question somebody's asked you, for the open scarf, how many scarf one needs to do to become proficient?
Yes, it's also, I would say it's difficult because you never stop to learn. So I'm still learning on that. But I would say if you perform under supervision 50Ks, you're already quite good. With somebody can showing the tips and everything, which are important to make a correct scarf.
Fantastic. I mean, I wish we could carry on. There are quite a lot of questions, but in interest of time, we'd like to stick to time. Thank you so much, Pascal and David, for your excellent presentations, and everybody has enjoyed. I will remind you about our next master technique. So date for your diary, 22nd of November. We are doing the next master technique on tarsal coalition. The speakers are Rick Brown and Manuel Montegudo. So please put it in your diary, and I look forward to see you all. I would also like to invite you to the BOFAS EFAS Young Foot and Ankle Surgeon Forum on the 26th of October in Edinburgh. So if you haven't registered, it's an excellent program lined up, so please do register. Thank you for giving us time this evening. This is the feedback code for you to give the QR code for the feedback, and you'll get certificates after that. Wish you all a great evening and see you on the next master technique.